Dr. Viren Naik here. Dr. Viren, I met at a simulation event that was hosted at Fanshawe College probably about 6 months ago or so. Great presenter, a good speaker, and some very interesting information that he's going to present around simulation. And you'll hear from Viren that simulation isn't just the, if you want to call the fancy stuff within hospitals. There's a lot of simulation work that's going on for educating our learners across all spectrums of the healthcare system. So Dr. Naik is a professor in the Department of Anesthesiology at the University of Ottawa. In 2009, he was recruited by the University of Ottawa to establish a Skills and Simulation Center as the inaugural medical director. He's also currently pursuing his MBA at the Telfer School of Management in Ottawa, and pleased to have Dr. Naik here.
All right, good afternoon. How's everyone feeling? Good, good. All right, well, Jamie and I have two things in common. We both came in very late on a plane from the States. I was in San Francisco, and I need to leave right away after. So I'm going to start with an apology. If you have more questions, my email will be up because I have to go back down to San Francisco right away. And the second thing we have in common is both our wives are trying to kill us. Now, it's a little daunting to be up here and presenting to y'all because, and it's not the size of the room, and it's also not the fact that you've just had lunch and your eyes are starting to close a little bit, and I look to edutain you. And it's not just because I'm following Jamie, although it's a little bit because I'm following Jamie. But the most important reason that it's a little daunting because, as you heard from Michael, I'm into simulation. And I know that one of the better ways of educating the healthcare workers of the future is through different methods, and I'm going to talk about that. And maybe not so much standing up here at a microphone while your eyes get heavy and your bums get numb in your seats. So let me do my best to edutain you and tell you a little bit about simulation as we go forward. Now, as Michael said, I am an anesthesiologist, and some of you may recognize this picture of the first anesthetic given. What I was surprised to learn when I moved from Toronto to Ottawa is several people in this picture are still practicing anesthesia there. Now, you don't need to be an anesthesiologist to appreciate we've come light years, right? All of healthcare has advanced. Gone is the doctor with the little black bag, and we've been replaced by the modern healthcare worker, and you'll notice I didn't say doctor, who has a host of different diagnostic and therapeutic tools. And I could talk for the whole 45 minutes about what that thing is that she's wearing on her neck, because I don't think we'll be using that very much more. And I'm a little bit of a geek too, so I know we will continue to advance to an age of tricorders and needleless syringes, right? But let's look at our healthcare education. Look at this graduating class from the turn of the century, and contrast that with the graduating class that I just took the picture of. Looks pretty similar, doesn't it? In fact, our entire healthcare education system has been compared to some degree to tea steeping. Now, if you'll bear with the analogy, that's where we take our bright young people, or tea leaves, we put them in hot water or a program for 4, 5, 6 years, and at the end we get tea, or your competent practicing healthcare practitioner. And we can debate whether or not this makes sense to anyone or resonates with anyone, but the fact of the matter is that one of these things is not like the other. And I've loaded the deck a bit, right? Because before you get launched into space on a space shuttle mission, you have to demonstrate all the competencies that you may need to do both routinely or in an emergency. My kid in their karate class has to show all those punches and all those kicks before they let her have her yellow belt. But our healthcare education system is still pretty much one of, hey, come spend some time with us, slap you on the back, and off you go. It certainly doesn't speak to the things that Jamie was talking about, and it certainly doesn't speak to the achievement and the stretch towards quality. In fact, all that our current healthcare system speaks to is the old adage, see one, do one, teach one. And I like to argue that's all well and good, provided not on my mom, right? I'm not going to knock this too much because a lot of you in your chairs are going, I didn't get trained very well. The fact of the matter is, yes, we all lived in this system and we probably did get trained well, but the fact of the matter is we have barriers to training that maybe didn't exist when the likes of us trained. We have the exponential growth of knowledge and technology. We think that medical knowledge and technology is doubling every 6 years. So how do you learn all the things that we've always had to learn on top of that exponential growth? Now, I also wear an administrator hat, and I'm saying the same as your administrators that we need to get more patients through the clinic, care for more patients in home care, get them through the operating rooms. Well, that's in direct conflict with education, right? Because when you're learning something new, it takes more time and it costs more money. How many of you have teenagers or had teenagers? How do they learn today, though? Like you and I learned? Up in our bedroom with a little fluorescent light over our homework? No, right? Where are they sitting? In front of the TV, okay? iPhone in one hand, texting their friends, doing a multitude of things, and we can continue to complain about the generation before us or accept that every generation is worried about the one that's come before it. And instead of complaining about it, start to adopt our education styles to match that generation. We have the push to work hour reform, realizing that being up for 18, 24 hours in a row, caring for people sleep deprived is not a good thing, although you can give a phenomenal talk when you're sleep deprived. And of course, we have ethical concerns, and they come first, thankfully, from people who are learning new things, who are starting to say, you know what, in that quest for quality and safety that Jamie talked about, I'm not comfortable being in this situation. I've never done this before. But of course, also from the patients, who are getting a world of education from the media, right? They used to get their education from shows like these. Shows that showed the doctors and nurses and healthcare workers as all-knowing and infallible, right? Where do they get their information now? Shows like these, right? Shows where the plot lines often revolve around the mistakes that doctors and nurses and healthcare workers make on patients. And we can again debate how realistic this is, or we can accept that they're somewhat rooted in reality. In fact, the only way that I think they really go into fiction is they always show the surgeons as the best looking doctors when we know it's the anesthesiologists, right? As professionals, we always have to balance. The difference between a trade and a profession is we push the system, right? And as healthcare professionals, the three balls that we continue to juggle are patient safety, research, and education. And I'm going to touch on each of these three and then talk about how we can improve the system. Let's start with education. I'm going to boil it down to the biggest bucket I can. Whenever we're learning something, whether it's shooting a puck at a net, whether it's playing your violin, we're trying to achieve this mastery asymptote, right? And when we're starting our learning, you have that steep part of the learning curve, right? Where you're getting better very quickly, you're learning new things, and then eventually you move into that part of the curve where you're starting to master your skills. So how do we move people through these parts of the curve? Well, sometimes the best lessons are the old lessons, right? Confucius told us, I hear it, I forget it. If I see it, I remember it. But if I actually do it, I understand it. And the good news is, in the 21st century, we have a lot of different ways of teaching. We have lectures, we have PBLs, we have case studies, we have self-study, all these different things. What do we do most of it? Number one, right? 90 to 99% of our teaching still continues to be this lecture seminar kind of teaching. And how effective did I tell you that is? Not very. I don't want to throw the baby out with the bathwater, but the fact of the matter is that passive learning, like what we're doing today, is wonderful, right? You'll hopefully resonate with you maybe a couple hours after I talk, maybe into the evening, but you can see, just like the child on the left, passive learning eventually starts to drip out. We want to engage in active learning where we're actually filling the bucket. Now, again, we can't throw passive learning away completely because you do need those root knowledges, those root skills before you can engage in active learning. So if you still need that passive learning, how can we do it differently? How many of you have heard of Khan Academy? Anybody? Oh, only one or two people. You say, well, okay, well, I'm about to enlighten you. Salman Khan is a gentleman out of the United States who's essentially the godfather of the flipped classroom. And he's revolutionizing the way that you learn math in grade 5 in the United States. Because now, your homework is to go home and watch the lecture of Khan Academy on how to do your multiplication, your addition, your subtraction. So what do you do in class? Well, in class, you're doing the active learning. You're doing those homework exercises that the teacher gave you with the teacher in the room, so the teacher can see where you're making the mistakes and correct the mistakes. We're parking that passive learning into the other media available to us. Salman explains it better than I ever could.
They were saying that they preferred the automated version of their cousin to their cousin. At first, it's very unintuitive, but when you actually think about it from their point of view, it makes a ton of sense. You have this situation where now they can pause and repeat their cousin. Now they can, without feeling like they're wasting my time. They could, if they have to review something that they should have learned a couple of weeks ago or maybe a couple of years ago, they don't have to be embarrassed and ask their cousin. They can just watch those videos. If they're bored, they can go ahead. They can watch it at their own time, at their own pace. And probably the least appreciated, aspect of this is the notion that the very first time that you're trying to get your brain around a new concept, the very last thing you need is another human being saying, do you understand this?
So if we can agree that we can take that passive learning and put it in a better environment, how then can we change our learning and change the way we're teaching through the steep part of this learning curve to embrace active learning strategies? Because I think the other thing we need to appreciate in that see one, do one, teach one philosophy is this steep part of the learning curve, this is not a quality part of the learning curve. This is a part of the learning curve that arguably is patient unsafe, and there's got to be a way to move through it. So there's lots of different active learning solutions, but I'm going to focus on simulation. We think that modern healthcare simulation got her start with this old girl. Anybody recognize her? Resuscian? Remember, you used to pull her out of the water, do mouth to mouth, and then the teacher would clean her off with some pool water, and the next kid would go? It took a little while for that technology to catch up with the idea. We've moved a long way. We have standardized patients, which are actors that play the role of patients and give us an opportunity to practice our history and our physical examination skills for all the new learners, or maybe if you're learning how to take a different history or physical. We have part task trainers like this one, simple things like this to administer, how to administer an injection. And it's not just to teach healthcare workers, it's to teach patients and non-healthcare workers. And in Ottawa during the H1N1 crisis, we used a model just like this to teach all these different people how to administer the injection so we could get a better distribution of the vaccine during that time. We have platforms in collaboration with the abattoirs around Ottawa, where we take the parts of animals that are otherwise going to be discarded and incinerated, and we bring them to our simulation centers so that you can learn procedures like how to take a gallbladder off of a liver, a common surgical procedure. But imagine, before this, it was done for the first time on your first patient for the very first time. And we have the full body mannequin simulators that I'm going to talk a little bit more about. And these are mannequins that talk and breathe and respond to medications that you administer, very, very lifelike. I'm going to tell you, and I'm about to ruin the simulator business for some of my C-Star friends, but the most unrealistic thing about simulation is the simulator. The most important thing is recreating the environment. Recreating an environment that you care for patients, recreating the people in the environment that you need to interact with. And we're going to talk about that some more. I'm not a very smart guy. This isn't rocket science. Why does this work? Well, here are the 4 not-so-secrets of simulation. It's pattern recognition, the importance of emotion and learning, the importance of debriefing, and the importance of practice. So what is this pattern recognition? Well, Jeff Norman and Glenn Regier will tell us it's the efficiency of retrieving an item from your memory, and it depends on how that memory was encoded. Well, what does that mean in normal human speak? It means that in a simulator, I can expose a person to this rhythm, or any encounter, or any procedure that they may need to know in order to care for patients. But more important than that, I can also show it to them in a context-sensitive environment. So in this situation, for an anesthesiologist, because it's near and dear to my heart, in an operating room, during a procedure where this may occur, during a part of the procedure where this may occur, so that when a person sees this in real life, they recognize it as being ventricular fibrillation and not something else. They recognize the pattern. We know that emotions are very important in engaging a learner, and what we do with simulation is we engage them in zone 1, awe, satisfaction, and curiosity. We can also, that's not good. Oh yeah, can you, the AV guy? Okay, thank you for engaging in my simulation. Because what you can also do to get good learning is engage people in zone 2, disappointment, puzzlement, confusion. That little moment there is something you'll always remember because it was constructive learning, constructive teaching. We avoid slipping down into zone 3 and zone 4 by debriefing. And all of simulation works on Kolb's cycle. And this is the same as for the pilots, the same as for everyone. You actively participate in the simulation. No teaching or learning happens while the simulation is happening. You have successes, you have failures. You manage it all the way from the beginning, all the way to the end. All of the learning happens after, in a debriefing, where we talk about those successes, we talk about those failures. We give an opportunity to reflect, interpret, compare what they know, and form a new way of thinking about how they're going to approach that procedure, approach that encounter. But more important than any of that is that you go back into the simulator again and again and again until you feel you've got it. This little video will show you what we do in the simulator.
Simulation terminated. Simulation terminated. Simulation terminated. Simulation terminated. Simulation terminated.
All right, Mr. Bile, is it?
My friends call me Phlegm.
Uh-huh. Mr. Bile, can you tell me what you did wrong?
I fell down?
No, before that. Can anyone tell me Mr. Bile's big mistake? Anyone? Ugh. Let's take a look at the tape. Here we go. Right. There. See? The door. You left it wide open. And leaving the door open is the worst mistake any employee can make.
So a little fun video from Disney's Pixar, but it tells you exactly what we do. Managed all the way from beginning to end. Learning happens after in a debriefing, a little more constructively than that. And you can see the learning's not just from the person who was in the hot seat, but also their peers who are learning by watching passively. We know debriefing is one of the most important things. This is a study we did a long time ago, and you can see that bar on the left. If you go from simulation to simulation, not only do you not get better without a debriefing, you actually get a little bit worse. Debriefing is paramount to the learning. And for those of you who doubt the power of video in learning, you've never had your golf swing analyzed. Because if you've had your golf swing analyzed, you know that they can tell you all day and night to keep that left arm straight, but until you see it in a video, you don't really appreciate it. And probably the most important thing that simulation brings is the fact that it's not practice that makes perfect, but perfect practice that makes perfect. Work done by Anders Ericsson tells us we need a certain number of hours at anything in order to move from being novice to expert, whether it's shooting that puck at the net again, playing your violin, or putting an IV in for the first time. And we think the tipping point is somewhere around 100 hours. Well, I'd rather those 100 hours be spent in a simulation center than for the first time on patients. I'm going to shift over to the ball of research for a second. I'm going to be very brief here because I want to get into the safety aspects. Because I'm always asked, does this make a difference? Yeah, you know, they learn better, et cetera, but does it make a difference on patients? Well, this is an emerging field, and the bottom line is yes. Research is emerging to show what simulation can do for actual patient care. Look at this simulation for inserting central lines. Well, we've shown at Harvard University that learning on a simulator like that can significantly reduce the number of bloodborne infections and all of the sequelae that occur compared to a similar cohort group. What about this simple simulator for learning laparoscopic gallbladder surgery? This one's a virtual reality one. Looks just like a video game. Does this make a difference on real patients? Yes, it does. Again, looking at work done by Gunnar Ahlberg and Tidor Grantroph, you can see the group, the virtual reality group in black, and Tidor's results lower. And I know the graph's a little bit complicated, but the bottom line is a significant reduction in the number of predefined errors that you make on actual patients. And what about full body simulators? And again, the most unrealistic thing here is that mannequin under the drapes. Can you learn how to take a patient off of cardiopulmonary bypass or any sort of encounter or anything that involves a team better if you do it in a simulation? And again, the most important thing here is recreating the environment, bringing the surgeon, bringing the perfusionist, bringing the anesthesiologist, so you can practice the communication, the collaboration that needs to occur to do this. And yes, again, it makes a difference. Simulation is clearly more effective at teaching how to take a patient from bypass. And that's a surrogate for many of our emergency encounters. So that was very quick across research, because I really want to talk about how this impacts safety. Because as you heard from Jamie this morning, the fact of the matter is to err is human. Jamie also brought up Ross Baker, who's, if you haven't heard of him, famous Canadian. And Ross told us that we're not immune to this in Canada. 1 in every 10 hospital admissions results in some sort of an adverse event. And 1/3 to 1/2 of these events are highly preventable. I'm sure this is true across the spectrum, not just in hospitals. And Jamie also talked about us needing to be considering ourselves a high reliability organization, one that is intolerant of errors. And numbers always get thrown out, right? Well, if we're intolerant of errors, what kind of numbers are we talking about? And numbers get thrown out: 1 in 1,000, 1 in 10,000, 1 in 100,000. So I just picked 1 in 10,000. So what does 1 in 10,000 mean? Because, numbers don't mean anything unless they have context. So I Googled it, and if you Google 1 in 10,000, you have a 1 in 10,000 chance of bowling a perfect game. You have a 1 in 10,000 chance of becoming a pro athlete, and you have a 1 in 10,000 chance of being injured by a toilet. And I'm not really sure what that even means. But you heard from Jamie, and it's not that we coordinated our talks, but it just shows how we're all beating the same drum, about Sully Sullenberg, right? The famous story that he says. And let me give you a little more to add to the story that he started. Not only does Captain Sully say that it was because of routine and because of standardization and all those other things that he put that plane down, but he also directly attributes simulation as providing the platform to practice those things. And when I say to practice those things, it wasn't about practicing how to move the joystick or to drop the landing gear or not drop the landing gear, as the case may be, but equally important was how to communicate with his co-pilot. I would say even more important, how to communicate with his crew so that everyone got off that plane. 1 in 10,000 is the chance of a bird flying into your engine of your airplane and having to do something like this. But the aviation industry takes it seriously. So seriously that while I tell you that 1 in every 10 hospital admissions results in an adverse event, I can fly every day for the next 157 years of my life and not have an in-flight aviation incident. 1 in 10,000 is also a can't intubate, can't ventilate situation. It's a little video I'll show.
Dad to 2 young children, Victoria and Adam, and this is the story of the death of my wife, Elaine, who died in March 2005 as a result of an attempted routine operation that went wrong. I'm an airline pilot with a background in human factors.
Very good health, but she had suffered from some sinus problems, and as a result, a consultant had recommended that she should have routine sinus surgery. That when Elaine had been anaesthetised, her airway had collapsed, that the oxygen levels in her body had fallen to very low levels, and so they decided that the safer option was to let Elaine wake up naturally, and unfortunately she hadn't done so.
Fit, they tried a second mask.
Why am I having problems here? I don't know, I'll open this. Hold down a bit, well, let me push the head back a bit more.
They then tried some extra drugs to try and reduce some suspected tension in the muscles in the jaw. So it was obvious almost straight away that things were going wrong. The patient, my wife, is blue. Her oxygenation is 40% or lower, and it has been for 6 minutes. The anaesthetist has 16 years experience, and he is regarded as diligent by his colleagues. The ENT surgeon has over 30 years experience. The other anaesthetist has additional skills pertaining to difficult airways, and 3 of the 4 nurses are all experienced in their job. there was certainly a loss of awareness, an awareness of time, but also an awareness of the seriousness of the situation. If you like, the awareness of what was happening wasn't shared by each of the consultants. At the inquest, 2 of the 4 nurses stated that they knew exactly what needed to happen, but again, to quote from the inquest, didn't know how to broach the subject. We have a breakdown of leadership, of situational awareness, of prioritisation, of decision making, of communication, and of assertiveness. And these same factors, these same human factors, ironically are present in 75% of aviation accidents. Human factors tells us that actually we're all wrong no matter how good we are, and we need people around us to help us. It's creating that open environment within your colleagues, being open to suggestions. If they put their hand up and say, "Excuse me, I'm not sure about this," it's not turning around and saying, "Actually, I'm the boss here." It's turning around and saying, "Tell me what your concern is." It's listening.
So that's a powerful video from Martin Bromley, and the whole thing's available on YouTube if you want to ever look at it. But it resonates with you to some degree with some of the messages that Jamie was sending, is that it's not an individual sport, right? This is a team sport, to say the least, and a system sport. And you can see how important that those human resource management skills, those crisis management skills come to play. Because unfortunately, I've shown you this mastery asymptote before, and I've alluded at the beginning of the talk to the fact that this is all about the trainees. It's not just about the trainees. It's about each and every one of us in this room. Ask yourself, when's the last time you did your BCLS training or your ACLS training, or some skill that you need in case you walk into a person's home or into the nursing home or into the hospital that you need. Because in reality, what we know, unfortunately, is this isn't where anyone in this room is functioning. This is where you're functioning. Not a very pretty curve. And we know that from work done by class, that what we know is that our skills, and not by any fault of our own, you heard about that exponential growth in knowledge and skills, etc. We know that things fall off. Simulation has the power to elevate that bar back up. Push us again towards the mastery asymptote, towards that quality agenda. If we were to hone down on that mastery asymptote, it actually looks a little bit more like this, in a more microscopic level. Now, where the good news is, where we live most of the time is up here, right? We live up in this level when we're doing our routine work. We have good days, bad days, little peaks, little valleys of days that aren't so good, and we're fairly consistent across routine work. The problem is, how much of our job isn't routine? You know, as an anesthesiologist, they say 90% playing crosswords or Sudoku, right? And 10% panic. Well, ask yourself, how much of your job isn't routine? When you're doing aspects of your job that aren't routine, you fall back down into that dangerous, steep part of the curve. And we know we know that when you do your ACLS or BCLS training, how long does it stick with you if you're not using it? How many people think 2 years? How many people say 1 year? Okay, a couple 1 years. How many say 6 months? Okay, a couple 6 months. Okay, the answer is 3 months. So you passed your ACLS, you got the card in your wallet, all good. If you don't do it once, it's probably lost a lot of your skills within 3 months. Simulation has the power to allow you to continue to practice those skills, keep going with those skills. And we talked this morning a lot about systems. Simulation also has the power to identify where there's a systems gap and maybe come up with a solution to address that systems gap.
Time and chaos could stand in the way of success, especially in a teaching hospital where it's not one, but a dozen doctors who race in to help.
I have no pulse.
When the heart stops, code blue is called. That brings in reinforcements. Suddenly, the crash kit and more doctors and nurses rush into the OR.
This is a gentleman in a VFib arrest.
It's a chaotic and stressful time for medical staff.
Everybody wants to have a role to play, and when you get that many people
In the room, it becomes very confusing. Nobody knows if anything has actually occurred.
With so many people in the room, the problem becomes who is doing what.
When you come to a code in the operating room, you can imagine everyone's wearing blues. Everyone's got a mask on and a hat.
Sometimes you come in the middle of a situation and you don't quite know who's who and who's running this. Who's the leader here?
This code is a simulation in the name of research. 2 Ottawa hospital doctors are trying to eliminate code blue chaos. They're testing a new system that could have amazing results. It's simple. If you're helping revive the patient, you get a tag. Your role is defined. Everyone else must stand back. The tags eliminate confusion.
You know what your role is, and everyone knows, okay, I don't have to do that role to shock the patient. Somebody else has that role. So you're taking out redundancy, you're taking out the chaos.
So we're using simulation to define systems, to take a systems approach to all of this. Because again, we know that from the talk that Jamie gave this morning that it's systems that's the level we need to act at. And I alluded to before that we have to appreciate this as a team sport. And if nothing can illustrate that better than the fact that if I put up this list of names, does anyone recognize who they are? One person, same guy who, what was the other thing you did that you put your hand up for? For Khan Academy. He knows everything over there. Okay. You obviously don't know this list, right, guys? Nobody's that clever on that list. Arguably not tremendously individually competent folks, but arguably the greatest team ever assembled. Contrast that with this list of names. Anybody recognize them? Tremendously individually competent people. And the great shame of Athens, right? Bronze medal. It's a little bit more fun way, but it highlights exactly what Jamie said. Would you rather go to the hospital that has a safety record or the surgeon who has good results? What I've tried to do very quickly is talk to you as professionals about where you want to push across these 3 different balls we're juggling, patient safety, research, and education, and show you how we can maybe bring those 3 together under a simulation-like agenda. For the administrators and boards and members in this room, the one question that always comes up is how much does this all cost? Well, the challenge is simulation is never going to be revenue generating and keep you in the black. In fact, it's often well below the break-even point. But you can't measure it in the dollars that come back directly. Instead, you need to take that balanced scorecard approach, decide what the measurable deliverables you want in your organization, show that it makes you be accreditation ready, it shows that it improves your efficiency of your staff. It may bring in some dollars. It's decreasing adverse events and improving clinical outcomes. It's maybe even decreasing mortality in your institutions. It might increase your staff loyalty, and we can start talking about how it improves the overall patient experience. There is some traction. In 1999, there were all of 6 simulation centers in Canada. CSTAR was one of those first pioneers here in London. Now there are over 180 simulation centers and programs across the country. So the resource is out there and exists. It's a question of how we're going to start to exercise and use that resource appropriately. We can measure the impact of simulation across Kirkpatrick model, reaction, changings in attitudes and perceptions in the way we approach things, knowledges and skills, changing behaviors, changing our organizations, and starting to benefit our patients. One problem with simulation is it's lived in this valley down here for too long. We've had the, oh, I liked it, I had a good time with it. But I've shown you some evidence that we're starting to change knowledges and skills. And I think that your organizations are starting to realize the impact simulation can make and are starting to be more interested in investing in it in some way so that ultimately we can benefit our patients directly and indirectly. Now, Jamie said that all great presentations, and I'm not going to say I'm on par with his, but ends on a quote. Well, I'm going to end on a Wayne Gretzky poke. And I'm going to say that simulation can allow us to start leveraging and enabling that quality and safety movement by skating to where the puck is going to be. I'll stop there and entertain any questions you may have, and I'll put my email up for any that you want to send me. Thank you. One over here. Oh, sorry. Hi.
Can you tell me the resources required to implement some of the strategies and where we might find them?
So as said, now the growth of simulation centers is actually still growing steadily. So my last count is somewhere around 180. It's probably growing to the 210, 220 with more every year. So the resources actually exist. I think the thing that people struggle with is, how can I get that Taj Mahal that C-STAR has or that University of Ottawa has? But the fact of the matter is you don't even need that. You can go to the Bay and buy a mannequin that they're not putting clothes on anymore. The Bay, or which one's gone out of Target's about to go out of commission too, right? Get a mannequin from them, bring them to your environment, dress them up like a patient, start to look at system gaps that you may have. Start to talk about how we're going to get this mannequin up the stairs in the case of a fire or down the stairs in the case of a fire. It doesn't need to be the expensive things. You can do in situ simulation everywhere you are. For those of you in family care centers with family doctors, I know many of them who decide Thursday every week at lunch hour, we're running a simulation. What are we going to do if our patient drops? What's our plan? What's our protocol? What's our system? How do we know to pull the landing gear back in? This, as I said, isn't rocket science. You can do it anytime, anywhere. Sorry.
In addition to cost, what are some of the barriers to implementing some of the strategies? Or maybe the other question is, where it's been successful, where it's spread, what was in place to actually make it spread?
Fair enough. I'd be remiss if I didn't just echo what came out, I think, in Jamie's presentation. Probably the biggest barrier is culture, right? We're all very smart people, we're all type A personalities. What does simulation do? Well, it exposes our flaws and our places where we can improve. We know from lots of studies that we've done and surveys, it's incredibly intimidating to get people to come to the simulation center, because who wants to show that they don't know how to do CPR or put an IV in the correct way? We need to shift the way that we think, and that again comes and echoes right off of Jamie's talk, from leadership down. This needs to be our culture that we strive for. There are no mistakes that we don't learn from. There are no punitive things that happen from mistakes. And if we can do that, then we actually shift to the pilots, right? That's what the other thing in the pilots is. They have a culture of learning from simulation. They have a culture of embracing it as an important part of their practice. We don't really have that yet, and we need to start shifting our thinking. And like I said at the very end there, that it goes beyond just our healthcare trainees. It's actually for all of us.